ER, we had this little device, which I don't remember what it's called, but it's to keep your airway patent. And it was shaped like a letter J. It had a top and then a hook, and it was plastic, and they had different sizes. And you'd open up this case, and you would measure from the corner of their mouth to the end of the ear, and that would be the size that you picked for the patient. And then you would stick it in their mouth sideways, and then you turn it. So you'd put it in like this, and then you turn it, and that would hold the tongue open. I don't know if they still use those or not, but absolutely it was something that you can use instead of having to keep opening the jaw. And then you could also put tubes down the throat at the same time with that in there. Again, it kept the tongue out of the way, but once you put a tube into the airway, you could like take that out. And that's how I remember them. But some people say they remember J codes have to do with the lungs and breathing because it looks like a fish hook, and fish can't breathe out of water. So again, whatever works for you. The code range for the respiratory system is J00 through J99, and these are Chapter 10 codes. Anything that can and will go wrong with the respiratory system. There are a lot of notes at the beginning of the chapter that you want to pay attention to, but anatomy is pretty important here. So let's go over that. This is not a structure of the circulatory system. This is the respiratory system. So please disregard that mess up on the slide. It's not supposed to be structures of the circulatory system. I don't know why I didn't catch that before. But the lungs is the main organ that exchanges the gas, but it's the organ itself. All right, so let's break down how we get to the respiratory system and the other parts of the respiratory system and the parts of the lung and the inside of the lung itself. So the trachea is the windpipe, right? That's the tube. Now, the esophagus is from the mouth, goes into the stomach, but the trachea goes into the lungs and or into the bronchi. But that's why when someone's going to be intubated, they're very careful to auscultate the lungs and auscultate the stomach as well by pushing air in, because if they don't hear air in the lungs but they hear it in the stomach, then they've gone down the esophagus instead of the trachea, and could result in death. Because you don't want to be oxygenating the stomach. Also, from the trachea, it's going to go into the bronchi, which is that area that you see that comes down and then bifurcates. You have two bronchial passages, comes down and then goes out. The larynx is the voice box. Right? I know someone that just had surgery the other day that had her larynx removed. She had cancer of the larynx. So you don't see that happen very often. The pharynx is the back of the throat, and then the vocal cords are where we actually get the speech, and that's in the larynx. Okay, so the larynx is the voice box, but the vocal cords are what does that's inside the larynx that allows us to articulate make the sounds come out, and then our tongue and mouth articulate the words. Respiratory system, that you need to know every single one of these terms. Probably, I would say you probably know most of these without realizing it. You may not know what the sphenoid sinus is, the sinus at the back of the throat, but just so you know that sinus just means cavity, or like a cave. So you have a cavity that's the sphenoid, the back of the throat. You have the frontal sinuses that are here. You have the nasal cavity, of course, and then the nose. So we know that. The epiglottis is this great little flap that protects the lungs, so that fluid and liquid doesn't get down from the throat. So we want liquids and fluids and foods and stuff to go down the esophagus, not through the larynx and into the trachea. And that little piece of tissue opens and closes, and your body does it without you even thinking. So if you get choked, it means something back there by the epiglottis tickled, and or something tried to get past the epiglottis, and then you choke and it comes back up. One of the great things to know about the epiglottis, and here I'll help you with murder mysteries and things, that is something that's involuntary. The epiglottis works involuntarily. So the brain helps the epiglottis do its job. You don't have to think about every time you take a drink of water to close the epiglottis so that you won't drown in your iced tea. So that's one of the ways that they can tell if a person was dead before they went into the water or they drowned and they succumbed due to being submerged from the water. Because if you didn't know, when you drown, actually you suffocate. Okay, so and when you see people that like cough up water after, like in a movie or something, they don't necessarily do that like they do in the movies. But what happens is that's actually coming from the stomach. Okay, and if you are if your brain is even remotely working, it will close the epiglottis and there will be no water in the lungs. Now it can get in the stomach, but it won't go in the lungs. Okay, now, but if you are dead, if the brain is not working, the muscles and everything can't work for some reason, the epiglottis will be open and the lungs will fill up with fluid. So if you drown, your lungs will be clear of fluid because you suffocate, actually, and because the epiglottis is working. And if you have fluid or anything in the lungs, that means sometimes people will have a heart attack and die and then fall into the water, and then that epiglottis opens up and it allows the fluid to go into the lungs. But if that epiglottis is working when you went into the water, it's not moving. It'll usually stay there. Okay, the larynx, we talked about that, and that's where the vocal cords are. The trachea is also rigid, because you got to protect the trachea. Then it actually bronchus, they break off, and you've got the left lung and the right lung. You have the mediastinum, which is right down the middle between the two lungs. The diaphragm is the organ that moves up and down and helps the lungs expand and close. Then if you look, the nasal pharynx, again, is that area between the nasal and the throat cavity. Oropharynx is the back of the throat. The laryngenopharynx is down by the larynx. Esophagus, of course, and then your lungs. Now look, after you get to the bronchus breaks out in the lungs and have tree that's like a tree, and then it gets smaller and smaller until it ends up in these little sacs called alveoli, and that's where the chemical exchange of oxygen actually helps or happens, is right there in the alveoli. And different diseases affect different parts of the lung. So for example, COPD is an obstruction somewhere, a chronic obstruction, but emphysema is a obstruction and a change in the anatomy of the alveoli itself. So it's good to understand that. So if we deal with anything that's an acute upper respiratory infection, that's going to be a J00 through J06. Keywords: acute, sudden onset. Upper part is going to be above the lungs. Okay, we're not getting into the trachea, right? So what could happen in the upper respiratory system? We could have nasopharyngitis. That's just a big fancy word to say the person has a cold. Sinusitis, those sinuses I told you about, they're irritated and inflamed. Pharyngitis, the back of the throat is irritated and inflamed. Tonsillitis, we know where our tonsils are on each side of our throat, and right before you get to the pharynx. Again, the tonsils are inflamed. Then we can have laryngitis and tracheitis. Now, laryngitis, mind you, we know where the larynx is, and often with laryngitis, we have the inability to talk because the vocal cords will be irritated as well. Tracheitis is just a little bit farther down. If you get obstructive laryngitis and epiglottis, that means that we've got something that is covering up, that is obstructing the larynx, right? That is different than just an inflammation. There's an obstruction, and that is when they say that the person has croup, and that's a high barking whistly cough. It's very unique. You can go listen to that on YouTube. It's children get croup, but adults can get croup as well. Then we wrap up the J06 with acute upper respiratory of multiple and unspecified sites. So we have a catch-all unspecified, it's going to be a J06, but let's say we have sinusitis, tonsillitis, and pharyngitis. Well, you may have multiple sites. Then you would just say, instead of doing those individually, you just have a J06 code. Let's look at the structure of the upper respiratory system. Again, trachea up, and we already, by saying what could be those first J00 through J06, the different things that could occur, it's all locational. And you may have not realized that some of these exist, like, did you know the pharyngeal tonsils are different than the palatine tonsil? Right? So you have more than just the two tonsils that you see when you look in the back of the throat. Okay, so you have the pharyngeal tonsils and the palatine tonsils, and usually if they're going to take out one set, they take it all out. Nasal pharynx, again, the back of the throat. Oral pharynx is down deeper. This is the tongue. Glossal. Lingual is where we get speaking, your language, your lingual. If the epiglottis is that little flap right there that I told you about. The larynpharyngeal, that's just down here by the larynx. The vocal cords. Esophagus and the trachea, so they're just showing you the esophagus is back here. The esophagus technically is not part of the respiratory system, but they're showing you locational. And there's cartilage that protects the trachea, and you can feel it when you rub your hands on it, little strips that protect that, because if you hurt that, since it's in front of the esophagus, if you hurt that, you're not breathing, right? If that closes, there's no air going in and out. The next section that we're going to be looking at, and notice that we jumped from J06 to J09. That's because we have room for growth in our code set. J09 through J18 is going to be anything that has to do with influenza, which is the flu, and pneumonia, right? So common cold is not going to be an influenza. They're two separate things. Can you have influenza and other things happening at the same time? Absolutely, you can, but they're two separate codes. So pay attention to if a person has a pneumonia, there may be a bacteria or something else that you may code in addition to identify what, because you can have viral or you can have bacterial pneumonia, several types of pneumonia. So influenza would be J09 through J11. So many types of influenza. You have the bird flu, you have influenza A, you have all different types. And the only way you're going to be aware of the different types of influenza or flu is to just look through J09 through J11 in the tabular. Pneumonia, all different types of pneumonia, like I just mentioned, J10 through J18. And just so you know, pneumonia will have laterality with it, because you can have pneumonia in both lobes, both sides of the lung, or in just one lobe, and you have more than one lobe. Got to know that anatomy. Acute other lower respiratory, so from the trachea down now, and we can have acute bronchitis, or bronchial passages that split off. Okay, bronchiolitis is, remember when I told you in the cerebral vascular that we had, you have your arteries, you have your arterioles, you have your capillaries, then you have your venules, and then you have your veins. Well, that's kind of happens in the lungs as well. So you have your bronchus, where you can get bronchitis, but you have your bronchiolitis, which is right after the bronchus, and is the smaller little pieces of the bronchus. So look at a stem of broccoli, and you have the main stalk, right? And then it breaks off into smaller pieces. It looks like tree limbs, and that's the bronchioles, bronchioles. And then the little pebbles, the little circles at the end of your broccoli, that is like the alveoli. Okay, so if we have bronchiolitis deeper down, that's a J21. But if we don't have specificity, then we just know it's a lower respiratory infection, you do have J22 to capture that. Upper respiratory diseases. Now we're not talking about just irritation. Now we're talking about diseases that can happen. Rhinitis. Rhinitis is different than just having an inflammation. It's a chronic type inflammation. Chronic sinusitis. Rhinitis is just inside the nose. Right. So if a person has rhinoplasty, they have something adjusted in the nose. Nasal polyps that can grow and obstruct. You can have abscesses, furnicles, and carbuncles of the nose. Chronic diseases of the tonsil and adenoids. We didn't even mention where the adenoids were located in the back of the throat. You need to be able to locate those. Peritonsillar abscess, meaning around the tonsils, can abscess. You can have peritonsillar abscess. I just watched a video the other day of, let's see, hand, foot, and mouth disease. They had a huge abscess, peritonsillar abscess, and then, or ulcer really, and then they had spots, this kind of odd rash. It almost made you think of somebody right before they broke out with chickenpox, but they had them on their hands and feet too. And so when you combined all of that together, which you can have chickenpox inside the mouth, but for it to be right where it was, and you had all of those, and it ended up being hand, foot, and mouth disease, which is a very unique thing. Chronic laryngitis, so something that just doesn't go away. You know, it's one thing to have laryngitis, might last a week, 3 to 7 days. But if you have it chronic and it goes ongoing, or you could have diseases of the vocal cords and larynx, which again, we could have a polyp, a tumor, a mass, something, or like my friend that had cancer. So if you have cancer, though, that would be a C code, right? Then chronic of the lower respiratory diseases. Okay, so this is your bronchial passages, bronchitis, chronic bronchitis, meaning it just doesn't never go away. Emphysema is that the alveoli changes. It's actually a change in the anatomical structure of the lung. Chronic obstructive pulmonary disease is COPD. This is kind of a catch-all umbrella because asthma and emphysema both are types of COPD. Then asthma, and you can have bronchial asthma as well as there's a whole list of different types of asthma, and you'll be able to find these in the J4 codes, but you need to pay close attention. Is it childhood asthma, acute asthma? Is it chronic asthma with an exacerbation? Is it COPD with asthma? Or, you know, so there's a lot of little variables you need to pay close attention to so that you can get to the highest specificity. And then we have bronchiectasis, which is like a buildup of fluid, like ascites in the lungs. If we have a disease in the lung due to something else that's an external cause, an external agent, they have their own codes, J60 through J70. So these are going to be things that happen due to exposure. Coal miner's lung, there's one that's called like ultimately it's guano. Bat poop in the lung. It's the dust and stuff. So people that were in caves, if they were a spelunker, you got this. Talc powder, talc dust and stuff can get in the lungs and cause irritation. Chemicals and gases and fumes and stuff that you breathe in or inhale. Radiation, of course, can destroy the tissue and break down the tissue, as well as different drugs. Note that if you use a code, especially here, that is involving a drug that has affected the lungs, you're going to be asked to identify what these things are, especially a drug. So if a drug was used and it affected the lung, then they're going to say, hey, use an additional code to identify what that drug was. Now we're moving on to diseases principally affecting the interstitium. Now, this is J80 through J84. So if we have, and this is more or less the workings of the lung. So acute respiratory distress syndrome, J80, this happens a lot of times with people that have asthma, and it's not respiratory arrest, but it's like that, similar. Pulmonary edema, so we've got fluid buildup in the lungs that's not pneumonia. Okay, this is pulmonary edema. Pulmonary encephalophilia, which is a type of blood, it has to do with the blood. You've got your blood components are affecting. And remember, we have that transition of oxygen from in the lung at that tiny level, that alveoli, and that's being transported through the blood. And then other interstitial pulmonary diseases. So that means they're listed, but we don't have a code for them. The pleura is the cavity that the lungs are encased in. So your lungs are always moving. And anytime you have something that's always moving in the body, joints, the lungs, the heart, for example, there's going to be a pleura around it in a pleural cavity. I mean, if there was no moistness or fluid around the heart and this pleura to protect the heart, that would be building up friction. So even if you just do this with your hand and you don't stop, it's going to heat up, right? Well, your heart never stops. Your lungs never stop moving. So there's a pleural cavity, and that can have irritation and complications. So J90 through J94, we can have pleural effusion. That means we have buildup of fluid in the pleural cavity. Pleural plaque, which is exactly what it sounds like the plaque that builds up due to cholesterol for the vascular system. You can have this plaque build up in the pleural cavity. Pneumothorax, which is actually a fluid that builds up and starts smashing the lungs. Okay, so you could have a pleural effusion that results in a pleural thorax. So too much fluid and it starts compressing on the lungs, and then it can also cause a tamponade and affect the heart, smush it up. Everything is really packed in there pretty tight. And so you get any extra fluid or buildup of an infection, pus, or even inflammation that makes something swell, it's going to affect other organs. But the lung is like a balloon, and you sure don't want to squish it. Then we have, of course, an area to catch those other pleural conditions that we don't really have a code name for. This can be like hemothorax. So you can have a hemopneumothorax, meaning we have blood build up as the fluid. Instead of just a pneumothorax of fluid, you can have air be the content that is in a pneumothorax, but hemothorax is blood that builds up that smushes, you like that good medical term, compresses the lung. And then you've got some unspecified pleural conditions, meaning we don't have specificity in the documentation to pick the code. The remaining categories are going to be J95, and then we have J96 through J99. So J95 are going to be those intraoperative and post-procedural complications that are going to affect the respiratory system. You know, there's actually quite a few. You get in there, and it's not that you're doing something to the lungs themselves. Anytime you have a procedure where you're given anesthesia and you traumatize the body in any way, even if you're fixing something with a procedure, and even if you're not working on the lungs, maybe you're working in the abdomen or something, but they'll have the anesthesia suppresses breathing. Anesthesia suppresses the lungs. And so we want your lungs, who are creatures of habit, to be quite honest, to work on their own to their full capacity and not be shallow breathing, because if you have shallow breathing, it leads to other problems. So respiratory therapy will often come in and have you blow and into that tube, and they'll have you cough and do lots of things to really keep those lungs active. This could be a post-procedural complication, you know, not even causing things like an infection or a bleed and stuff like that, you know, but keeping those lungs going. And then other diseases of the respiratory system. This is a pretty big range because there's so many other things that could happen to the lungs that aren't in a category in and of themselves, so that we've already mentioned. Guidelines. Well, COPD and asthma specific guidelines, because asthma is a type of COPD, and so is emphysema. And because COPD is like an umbrella, it is anything that is chronic and obstructive and is a disease that happens to the lungs, right? That's what COPD is, and asthma can do that. So when you have COPD and asthma, then there's some sequencing guidelines that you need to be familiar with. So pay attention to those, because you will be tested on all of this stuff. Acute respiratory failure is different than COPD. COPD is an obstruction. An acute respiratory failure could be due to asthma, it could be due to COPD, it could be due to a trauma, it could be due to a drug. Again, it's a sudden onset of the lungs not working anymore. Remember when we talked about the heart, and if the heart has an obstruction, right, that's an infarction. If the heart stops moving, that's a failure. Heart failure. Same thing with the lungs. If the lungs are obstructed and not working to their peak capacity, that's one thing. But if the lungs quit moving, quit doing their job completely, that's respiratory failure. And people can go into acute respiratory failure for all kinds of reasons. Influenza, make sure that you pay attention to the type of influenza that is identified, because things like the avian flu or the bird flu, there are specific guidelines in sequencing for that flu versus other types of flu. They'll be sequenced first. Ventilator-associated pneumonia. When a person has a procedure done, like I mentioned before, they can get a buildup, their lungs not working, and maybe they get pneumonia. Pneumonia can be common with certain procedures that are done in the body, or if you're under anesthesia for a long time. You know, pneumonia is just fluid building up in the lungs. But people who are on a ventilator, that is exposing parts of the body, the inside of the body, that is not supposed to be exposed to the outside world, right? Whether we're using a sterile technique or not, you know, to ventilate them and hook them up to a machine, we're still doing it in a process that's not normal for the body. And because of that, when people are on a ventilator, sometimes they can develop pneumonia. The body just says, nope, not going to do that. And so there are specific codes for pneumonia, and there's specific other codes for ventilator-associated pneumonia. They don't, now when I say other, I don't mean they're in the other category. What I'm saying is there's a block of codes for pneumonia. There's a block of codes for viral pneumonia and bacterial pneumonia. There's pneumonia associated to other things. And then there is one little area that says ventilator-associated pneumonia. You need to know what that is and make sure that if the documentation states that, then that's the code you use, not a regular pneumonia. So let's look at a little practice. Acute suppurative pharyngitis, which means it's producing something, right? We're coughing something up. Pharyngitis is our key word that we're going to look up in the index. Now, the modifying terms is we're going to go down from pharyngitis, we're going to indent, and we're going to see acute, and then we're going to see suppurative. Not always will it be suppurative and acute, but also suppurative is there. And it's going to tell us to look up JO2.9. We're going to go look that up in the tabular and see if there's any other information we need. There might be an indication that we need another code to identify an organism, if in fact that was was able to be obtained, and then you would have more than one code. And that's it. If you find anything interesting that you can share with us, the rest of the students, make sure you post it in the club. That's where you ask your questions. Okay, thanks. Bye, guys.